I'm going to talk about cardiac output and cardiac output monitoring. If you can just go on to the next slide, please. So, from the time I've started in intensive care nursing, I've learned that, or I've been told that the most important thing, or what we're trying to achieve in the intensive care setup, is two things. We're optimizing oxygen or oxygen delivery and cardiac output. That's what it's all about, basically. So I just want to show the slide. Firstly, on our left, we have basically what we've always known as our blood flow through the heart. Just quickly, we have blood from the superior vena cava and the inferior vena cava, both pouring blood into the right atrium. And then our tricuspid valve will open and the blood will then flow into our right ventricle, and then it goes through the pulmonary arteries into the lungs for oxygenation or gaseous exchange. And then we have oxygenated blood flowing back into the heart via the 4 pulmonary veins, which are the only veins that will carry oxygenated blood in our bodies. Into the left atrium, our mitral valve will then open, allowing flow of blood into the left ventricle and into our aorta and the rest of the body. That's just in a nutshell. Then we have cardiac output, which we have a stroke volume and a heart rate, which makes up our cardiac output. So it's SV times heart rate equals cardiac output. Now, cardiac output is basically, we have a preload, the determinants of our stroke volume or cardiac output are preload, contractility, and afterload. Our preload is then measured by our stroke volume variation, which I will then show on the monitor, and how to troubleshoot on our stroke volume variation. For example, you have a cardiac patient that has had surgery and you would like to know whether it's a fluid challenge or an inotrope challenge. We look at our stroke volume variation. Factors that would affect your preload would be your cardiac compliance, your atrial contractility, ventricular compliance, aortic pressure, and then your heart rate. Your venous return will also affect your preload, your venous compliance, vasopressors, regurgitation, and then your total venous blood volume, which would then be your fluids, hemorrhage, or stenosis. Then you have factors that would affect your contractility, which we look at the Starling law, which basically means that the more your cells contract, the more blood volume you will have until you reach a stage where you then cannot contract further, and then your cardiac output will then decrease. So you have factors that would influence your contractility, which is your ischemia, your hypovolemia, cardiomegaly. Your pH would then decrease with acidosis, your vagus nerve, and then you have things that would also affect it, like your hormones. And then again, we go back to the Starling law. And then you have factors that would then increase your afterload, which would be your aortic obstruction, which would be also your volume viscosity, your calcium, your pulsation. Then you would also have peripheral vascular resistance, which is affected by your hormones, your vasopressors, inotropes. And then we look at heart rate, which is your beats per minute, which is measured in beats per minute. You have sympathetic stimulation, which your vagus nerve would then decrease your heart rate. Higher potassium would also decrease your heart rate. Then you have, if you've got a higher calcium level, your heart rate would increase. If you've got a higher temperature, you'd have an increase in your heart rate, or you'd have tachycardia. If you have a decreased parasympathetic nervous system, you'd have an increase in your heart rate. Your hormones would also have an effect on your heart rate. Pain, anxiety, things that also cause increase in your heart rate. Your thyroid function, your T3 and T4 would influence your heart rate. If you've got an increase in your carbon dioxide level, your decrease in pH, your decrease in oxygen, you'd also have a higher heart rate. Drugs, your beta blockers, your ACE inhibitors, calcium channel blockers, for example, verapamil, would have an increase, an effect on your heart rate. Inotropes, for example, adrenaline, Witrex, those will also cause a tachycardia or an increase in heart rate. Vasopressors like your noradrenaline or epinephrine would also have an effect on your heart rate. So, nursing considerations at the bottom, you watch your blood pressures, watch your mean arterial pressures, know your normal values and your target ranges, because you might have normal values, but then more specific to your patient, you know what your target ranges are. This is basically what a cardiac output monitor looks like, or on the side, you can see just an example of one of a cardiac monitor. They're all hospital different, or they're different models basically, but the concepts are basically the same. So when we look at a cardiac output monitor, we should then know what to look out for. Why are we doing cardiac output monitoring? It's, in a nutshell, basically to know, as we've said earlier on, is whether you've got a problem with fluids, or you've got a problem with inotropes or vasopressors. I was supposed to do a demonstration, but because of time, we're just going to look at the board because they're exactly the same. So on your monitor, you've got a stroke volume, which is amount of blood ejected by the ventricle with each heartbeat, and it's measured in mils, of which, if we look at we've got 52. Our normal stroke volume should be 60 to 70 mils. Then we've got a stroke volume index. Anything with an index on our cardiac output monitor means it's indexed to specific body surface area. So that's why when you put on a cardiac monitor and you calibrate it, you have to make sure, again, the measuring tape, as Sister Renee has mentioned, with the patient's correct weight. Then we can manage the patient accurately or optimally. So our stroke volume index within this is indexed to body surface area. Then we have CI, which is our cardiac index, which is cardiac output adjusted to the body surface area. And we look at approximately 4 to 6 liters on each individual. We've got systemic vascular resistance, which is the pressure the left ventricle has to overcome to eject blood into the aorta, which is also known as our afterload. This is just, you can look it up on flow track system algorithms on your Google, but it's basically a very nice guide or algorithm that we have in monitoring our patients. So if you follow through, you've got an SVV which should be less than 13%. If we follow through, you can see if it says yes, then we go into a volume challenge. You can either give gelfusion, you can give colloids, or whatever volume you want to give your patient. If we go on to the next side, it says no. So then you look, okay, SVI on your cardiac monitor, 40 to 50, then you can give presses. If it's SVI low, which is less than 40, it's inotropes. If it's SVI high, which is above 50, then you would do diuretics. But again, we do not just look at one reading or findings. We look at the patient as a whole. So then we look at our curve, which is, as you would see on that cardiac output monitor, we look at that curve or waveform, and then there's the meanings on the side. In a nutshell, when we nurse patients in the ICU, we don't just look at a patient with one findings, whether it's your blood pressure, your pulse, but you look at the patient holistically. You look at your cardiac output monitor, you look at your hemodynamic monitoring, which is your CVP, your airline, and you manage the patient holistically, not with just one number. Or you can end up with hypovolemia or hypovolemia if you mismanage your patient. Hence, you do not optimize oxygenation and you do not optimize cardiac output. Thank you.
Can you keep that mic?
Do you have to?
Let's just borrow that microphone. Still on? Okay. So we got questions on the floor. You may have seen devices that you may not have come across before, but the point is to bring up the concepts of all the components of cardiac output. Go for it, James.
Cardiac surgery patients regarding cardiac monitoring, there are various systems. One of them is that we see the monitoring line actually being strapped to patient's arm. It's a little bit, to me, I think, I don't know what people feel, but where I came from in terms of training at Albulatuli, at the back of the bed, patient's bed, you actually have a bridge to hold those monitors. So which one do you think is better?
Can I answer that? From my experience, Dr. Chen, I would think that having it on the arm is more accurate because then you're able to measure the phlebistatic axis, which, as Lusanda had explained, is the fourth intercostal space. And it can stay on there, whether you move your patient's bed up or down, but it stays there, and I would think that that's more accurate. Whilst if you have it at the back, you don't have it at the same level all the time. You can change position, patient can go up, goes down, and then it would alter your readings. Again, we can go back to what I had forgotten to mention earlier is also in the ICU, we look at trends. So I guess in your case, I don't think it's wrong, but then we would then look at trends as to what readings we're getting.
Can I maybe comment on this one? Sorry, I have to throw 2 cents in here. I've worked with both systems, and I think the answer to this question is, it depends how good your ICU sister is, once again. Both systems are fine to work with. If you're lifting up your bed, the head of your bed, the only thing is your patient's probably then also awake and your arm is probably moving as well. So both of those things need to be taken into consideration. I personally also like the bridge more at the back, but then you need a wake-up ICU sister to be zeroing and levering off that transducer all the time.
Okay, any more questions from the audience? Okay, I think we've got a few more minutes. What do you consider is the most, when is a cardiac output monitor's data less reliable?
Okay. Well, Kath, thank you for the question. If you've got, for example, I'll make an example. If you've got an intra-aortic balloon pump, I would think that you would then have altered readings, because with the balloon, you then have a decrease in your preload. Hence, you wouldn't get as accurate readings. Again, we then look at your trends. It's all about trends. So if you have a change in your values, whilst you've been having a certain trend, then you would start acting. Otherwise, I would think that it wouldn't be accurate if you've got an intra-aortic balloon pump, or even if you've got invasive ventilation because of the change in your thoracic pressures, you also wouldn't get accurate readings.
Blocked airlines?
Definitely, definitely. Your blocked airlines, your ECMO, blocked airlines, your air in your lines, your kinks, all that, you wouldn't get accurate readings.
What about the site? Femoral versus radial artery monitoring?
Dr. van Raden, can you do us the honors?
Oh, that's not fair. Okay, the arterial waveform does change the further you are away from the heart. So if you measure a patient's blood pressure invasively in the radial artery versus in the dorsalis pedis in the foot, the dorsalis pedis is much further away from the heart. The pressure waves will have bounced against blood vessels more and more and amplified themselves, so that in the foot you find often a higher systolic blood pressure that's artificially been amplified. So knowing the site is important. The femoral artery is relatively close in that at least you're getting a big flow down the aorta going towards the femorals. It should have a higher integrity, especially if you have, say, diseased arm arteries. And so often those two are fairly comparable. But it is important to always document where is your site of measurement, because they can change. And if you've got two A lines in, one in the radial and one in the femoral, and then you swap measuring from one to the other, it's important to mention that you swap, because the readings from one may not be similar. Mean arterial pressure tends to be equivalent, but the waveforms change and systolic pressures can change significantly between different sites.
Okay, that's enough time. Thank you so much, ladies.